Assalamu alaikum students. Today I have very important topic for you, and uh, regarding the importance of this topic, this is commonly kept as a short notes for you, or short case for you in your final exam, and secondly, it comes quite often as a short note in your final exams. And old examiners are very fond of asking questions related to this topic. So we'll move on to the today's case. So today we have 10 years old boy. Okay, the patient is 10 years old boy. He had a history of supracondylar fracture about 2 years back. So it's an old history of the fracture. So it's one of the late complication of fracture. And how was it treated? It was treated by massages and bandages. So there is no the patient doesn't seek the orthopedic's opinion, but treated by a bone setter. So he had pain and swelling for 1 month after the fracture. So this 1 month is very important because after the fracture, the pain should subside by 1 week or 2 weeks. So if the pain is persisting for 1 month or more than 1 month, that indicate that there is something going abnormal in healing process. Then after that, patient now have deformity of the limb, numbness, and he is unable to open the fingers. So this is the disability patient is having now: deformity, numbness, and unable to open. So deformity indicate there is some problem with the joint, numbness indicates some problem with the nerves, and a lack of opening of the fingers indicates some problem with the muscles. So this is how the posture is. So this all this history should direct you towards the diagnosis of Walkman ischemic contracture. So what is Walkman ischemic contracture? It is the late sequelae of untreated or inadequately treated compartment syndrome. Okay, patient might have compartment syndrome after the fracture. This is an immediate complication, so in which there is necrosis of the muscles happened in the nerve tissue, and which was replaced by fibrous tissue. So what is the pathology here? There is trauma or insult to the limb. This is immediately after the injury. Patient have either muscle injury or the nerve injury, and it was not treated fully. So patient had fibrosis of the muscles during the healing process and the compression over the nerve and nerve damage during the healing process. And finally, patient has presentation that is Walkman ischemic contracture. So before moving to the topic proper, we'll just recall our anatomy. So what is important in the anatomy is we need to know the layers of the muscles in the flexor aspect of the forearm. So we have two layers, superficial layer and deep layer. So in superficial layer, we have 5 muscles, which is pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. And under that, we have flexor digitorum superficialis. When you lift this layer, we have 3 more muscles as a deep layer of the forearm, which is flexor pollicis longus, then pronator quadratus, and flexor digitorum profundus. These muscles are very important because flexor digitorum profundus is first to get affected in Walkman ischemic contracture, followed by the second common muscle is flexor pollicis longus. So this is why this anatomy is important, the superficial layer and deep layer of the forearm. We'll move on to the next slide, the causes of this one. So there may be a trauma, there won't be associated trauma, but increase in the compartment pressure. So the common cause is trauma. It may be either in the form of fracture or the soft tissue injury. Then after the trauma, if there is tight bandage application or dressing also, that increases the chances of patient developing compartment syndrome. Then after the amnimal bites, burns, neoplasm in the forearm, and bleeding inside the compartment. Bleeding may be after due to the injury to the muscles or vessels, or may some bleeding disorder also, like hemophilia. Then injection in the forearm, like drug abuser, they take injection in the forearm. So it may also induce the response, and inflammation may land up in compartment syndrome. And any surgeries over the forearm, and during the surgery, hemostasis is not achieved. So or late hemostasis is not achieved, or there is a lot of soft tissue injury during the surgery. So what are the grades? So we have 1, 2 grade and the 3rd grade. So what is first grade? Only involve flexor digitorum profundus. So this flexor digitorum profundus are responsible for flexion of interphalangeal joints. So it affects only the fingers. Whereas 2nd grade affects flexor digitorum superficialis and profundus, both. and along with the other flexor components. So we have flexor affecting the flexors of the wrist, affecting the flexors of the finger. So we have the combination of wrist involvement along with the finger involvement. Lastly, in the grade 3, it is so extensive that it involves the extensors also. So along with these flexors, we also have involvement of the extensors. So here there is no muscle left for any no healthy muscle left. All the flexors and extensor group had fibrosed due to compartment syndrome and now presenting as Walkman ischemic contracture. So if this is there, depending on the severity involvement, we have the following deformity. If it is grade 3, we have elbow flexion, forearm improvisation, wrist flexion if grade 2 or grade 3, thumb abduction in grade 1, and MCP joint extension grade 1 and interphalangeal joint flexion in grade 1. So depending on the involvement of the muscles or group of muscles or grade of involvement, patient will be having the presentation of deformity. Then there is also associated sensory deficit. Why have sensory deficit? Because ischemia has damaged the nerve also along with the muscle. So this is the presentation of Walkman ischemic contracture. So the one important sign you need to remember, Walkman sign. This is commonly asked in exams by examiner in practical. So just if you imagine yourself, these are the joints, okay? And these are the tendons attached to the joint. So what happens in Walkman ischemic contracture is there is relatively tendons are shortened. Tendons are shortened, relative shortening of the tendon. So if this is a position, the tendons are very tight. If you try to extend it, it start bowing because tendon cannot stretch to that extent. So there will be increase in the deformity. So this is what happening in Walkman sign. When you flex the wrist, the relative relaxation of the flexors. So when you flex this flexion of the wrist, the tendons relatively relaxes. So the fingers will go into extension. We have more movement at the finger. So finger extension improve when wrist flexes. When you try to extend the wrist, then there is relative shortening. So fingers will go into flexion and deformity increases. This is how it happens. If you extend the wrist, the flexors will try to bring the fingers to closer and patient will have increased deformity. This sign is called as Walkman sign. It is very important in your exam because examiner is definitely going to ask regarding the sign and the mechanism behind it. How will you diagnose? One is clinical diagnosis. So it's basically there is history of fracture, native treatment, patient had some problem during the fracture healing, finally patient has deformity. And we need to take the X-ray to evaluate the previous fracture. So how is the status of the fracture? How it's a malunited or it's any complication of the fracture we need to see. So once you have diagnosed, you need to treat it. So it's a tailored treatment. We can't treat all Walkman ischemic contracture one way. So it depends on degree of involvement. If patient is having mild, that is only involvement of flexor digitorum profundus, you can do physical therapy. We can give dynamic splinting, and sometimes you can do lengthening of the flexor digitorum profundus and sliding of the origin. So that will slide the muscles down and increase the relative length. If patient is having moderate contracture along with the tendon slide, you may need to do neurolysis and you need to go for extensor transfer. Because in grade 2, the extensor compartment is intact. There is no involvement of extensor compartment. It involves in grade 3. So we can use healthy muscles or healthy tendons of the extensor compartment and transfer it over the flexor aspect to take action of flexion. Then if patient is very severe involvement, that is grade 3 involvement affecting both extensor and flexor group, then there is nothing left in the limb. So you need to get something from outside or other groups. So we have to go for extensive radical debridement of the fibrostic tissue. And then we have to get the muscles in the form of free muscle transplant. We can get sartorius muscle, we can get the rectus muscle. All this we need to go for free muscle transplantation. So mild, you can do physiotherapy and tendon sliding operation. Moderate, you need to go for neurolysis, tendon slide and extensor transfer. Severe, you need to go for radical treatment in the form of muscle transplantation. So these are the few surgical things you need to remember. This is very commonly asked in an exam. It's called as MAC page release. What is max page release? As I told, there is relative shortening of the flexors. So there is shortening at the common flexor origin. What we are doing is we are cutting the tendons from the origin and lifting it up. Then you bring the fingers into extension. So from here, this will slide down here. So this is the sliding of the tendon. So this is called as muscle sliding of common flexor origin. Sliding of common flexor origin. This goes by name max phase. So max phase release is one of the important surgical treatment for moderate to severe, moderate contractures, Walkman ischemic contracture. So we give max phase release. We can do free muscle transfer. So here, if you see, we have excised the fibrous tissue and we got the muscle from other sides. We can get gracilis, sartorius, these muscles along with the skin covering and interpose in between the this muscle is interposed. And so we need to have vascularity also. We need to anastomose the vessels of this muscle along with the anterior interosseous muscles. Or we other thing is we can go for shortening of radius ulna. How it helps? As I told, there is relative shortening of the tendons. So if you shorten radius ulna, then also you see this is the length of the radius and ulna. So if you remove this amount of radius and ulna and shortened it, then the tendon, which is this one, now it got relaxed. So this is how the muscle shortening effect. So the bone shortening effect, so shortening of tendon. And sometimes you need to go for proximal row corpectomy. We can excise the scaphoid and lunate. So mind you, these are all salvage procedures. So we can remove the part of the bone to increase the performance of the limb. So it's a reconstruction procedure. Sometimes we need to go for wrist fusion. And when we are operating, we need to always attend to the nerve because nerve has fibrous tissue along it. So you need to go for neurolysis. This is all about Walkman ischemic contracture. It is very important topic and it can be kept in your final exam also. Please like, subscribe and share my videos. See you in next video.